video, we present the All-Arthroscopic Nanofractured Autologous Matrix-Induced Chondrogenesis technique as a valid option to treat osteochondral lesions grade 3-4 ICRS. This is the case of a 41-year-old patient with continuous pain and function limitation in his left knee. No improvement to previous 1-year conservative treatment and NSAIDs. As complementary explorations, Rosenberg and CHUS and long leg weight-bearing XRs resulted normal. 3 Teslas MRI showed an osteochondral 2 square centimeter lesion in the load-bearing area of the medial condyle. We proceeded to all arthroscopy treatment of the chondral lesion following the A-NAMIC technique. Before starting surgery, we organize on the table the required specific instruments and implant. Nano FX handles, thumb and pleuristic, open curette 4 mm, arthroscopy burr 8 and 10 mm, Mosaicplasty Trephines, collagen 1-3 biphasic matrix, fibrin glue, ruler and pen. Then we proceed to position the patient, supine decubitus, upper limb ischemia. We will work with 2 arthroscopy portals, anterolateral and anteromedial. First one for articular vision and the second for instrumentation position for direct perpendicular access to the chondral lesion. After everything has been set up, we proceed with the surgery. First of all, lesion localization and meniscus and ACL integrity and functional check, which resulted normal. Damage cartilage and sclerotic bone layer debridement using an open curette of 4 mm. Reshape osteochondral edges with Mosaicplasty trephine. Leave vertical edges. Nanofracture in spiral configuration for complete bone marrow stimulation. Leave minimum 2 mm between holes. We use Nano FX kit. It guides us to do reproducible 1 mm diameter by 9 mm depth holes. As soon as we complete the BMS, we proceed to lesion sizing with the 5 mm probe. We proceed to stop water entry and proceed to dry the lesion as much as possible. Then we start preparing the collagen matrix. First of all, localize the porous face, then hydrate with serum and afterwards cut the membrane with the same trephine we used to shape the lesion. Position the implant in the trephine. Porous layer facing the lesion and proceed to implant the membrane, pushing the trephine into the lesion. The porosity of the implant facilitates the adhesion to the lesion surface. Use the probe to reposition for better coverage. It is very important that the implant sits flat in the lesion area, covering all gaps. Also, important, the implant should not exceed the lesion edges. As soon as we achieve full coverage of the lesion, in this case with 2 rounded implants of 1 cm, we proceed to seal it with fibrin glue and wait a final 5 minutes to ensure correct jellification and implant stability. In this slide, we present the rehab protocol we recommend for this patient. Based non-8 bearing and continuous passive motion movement for 6 weeks. After the 7th week, we start with partial bearing and full active motion. Also start with non-impact sports such as cycling or swimming. After 12 months, we consider the new cartilage is already mature, so we allow high-impact sports from then on. Attached is the list of related publications. We would like to emphasize that the A-NAMIC technique has more than 10 years of follow-up with good results. Previous work of Pneumatic and Behrens define previous steps of this new technique, A-NAMIC.